we don't really think about that. Now we hear like of a 50-year-old dying, we go, oh my God, he was so young, right? That wasn't always the case. And so who knows, you know, there may be a time they go like, oh my God, he died at 99. He was so young. You know, who knows? I would love that to be the case.
I know you want to talk about regenerative medicine.
Good. Yeah, talk about what else.
Should. I think you should.
Yeah.
I think that should be something you talk about. We really haven't had a guest talk about that.
Yeah.
We've touched base upon that. That
Okay.
could be a little bit of fun. And then you can talk about pain, but I think you're trying to go a little bit more towards that path. So I can guide you that way if you want. And then how that kind of correlates with longevity, that's a kind of a hot topic, so I think that'd be good too, if there's some way you can bring those two together. If not, I'll feel you and I'll back out.
All right. So, yeah. I mean, because I don't focus on longevity. I don't do any longevity medicine. I mean, I
understand.
Yeah, sort of like every other layperson, you know, like the Peter Diamandis and, you know, and Peter Tia like books. I've read them, you know, and I've been like, oh, that's interesting, you know.
We're going, right? You know, he knows. I always have good conversations with you.
Well, yeah, but I was gonna say, but in terms of like, you know, is this my shtick? Is this like what I'm delving into? No, because I figure, you know, there are people who this is what they really focus their like, sort of like attention and all of their time on, and so they're going to be better at it than I am, and I want to be better at things that they're not going to be at. Yeah.
So what is that thing?
Well,
if I want to give you
everything else, no, I'm just everything else.
Because I will say, I think there's data starting to come out in the longevity world, okay? But I think there's more interest. I think that still correlates with the stem cells, the regeneration, right? Because anti-aging is being able to use my body longer.
Right.
It's being able to use it better, longer.
Right.
You and I have an appointment next week, which I have to move 30 minutes back because I don't want to be late. But for my shoulder. Yep. Right? And I want to continue to play water polo. And I'm playing at a high level and taking care of myself. Right. I'm doing as much of the best anti-aging you can that there's data on from outside of what you do. But if my body breaks down, you're doing it on the cellular level. You're helping me regenerate in a different way. You're helping me combat my aging and all the bruising and beatings and things I've done to my body. So,
well, this is, you know, so if you sort of parlay off of a lot of the longevity medicine sort of discussion and the interest, they talk about not just, you know, lifespan, but talk about health span, right? And
Correct.
So this is where health span comes into play, right? It's like, yes, I want to live longer, but I want to live longer and do the things that I enjoy doing. So I enjoy playing water polo. I want to be able to do that until I'm like 80 something, not, you know, done at 50 and then that's it. I can't play anymore. So I think, yes, there is a corollary from living longer to how do we make you live a better quality life so that you're able to do all those things that whatever it is, fill in the blank. I enjoy doing X and I want to be able to do it without pain and without limitations. And so, yes, that's why I come into play.
Yeah. And I still think that, I mean, you probably know this well, and if you don't want to dive into this, it's okay. We're still in the beginning stages of what I guess living longer longevity is. I'm very hyper focused on what does health span look like.
Right.
Can I walk with my grandkids at 80, 90? Can I maybe pick them up? Maybe. That's okay. Or at least pick a toy up without my back freezing.
Yeah.
Like things like that health span, that, you know, whether it's neurologically or just the physical capacity of power and strength to be able to do that. I think that's probably where people are. There's so much talk about living longer, which is great. But if we're not living a higher quality longer, then what's the point?
Yeah, what's the point? I agree.
Right. I don't want to live 20 years longer and be like in a chair.
Yeah, you're Gomer. Yeah, it's like, no. you don't be that person.
No, not at all. If I could live incredibly well until the day before I leave and just be able to be active and happy and move and talk and social, which is in all these books as well as we talked about, then I think that's it. And I think we can we're getting better at that.
Right.
Now, whether that creates more years, I think that's still what we're waiting to find out.
Absolutely. Yeah. I don't know. I mean, it's always interesting listening to some of the authors of these longevity books, and, you know, people talk about like living to 120, living to maybe 150, or, you know, like the first, you know, person to live to 150 has probably already been born, right? And
that's true.
Yeah.
Theoretically.
Right. But I don't know if that's true, right? And maybe it is, maybe it isn't. You know, I think man has been on the quest for, you know, eternal life since man has been around, right? And so this is not a new thing. I think hopefully the tools that we have nowadays allows us to tap into some of those secrets, like why does a Greenland shark live hundreds of years? Why does it? So it's physiologically, it's possible, right? And so, which also means that, you know, you can find that biological key that maybe we can unlock in our DNA that allows us to also live that long. I don't know, but I think the thing that we are really getting good at is improving quality of life, right? And you know, as it is already, you know, if you 100 years ago, living to, you know, the ripe old age of like 50 probably was like, thank God I could do that and not have a heart attack and die, right? And so we don't really think about that. Now we hear like of a 50-year-old dying, we go, oh my God, he was so young, right? That wasn't always the case. And so who knows, you know, there may be a time they go like, oh my God, he died at 99. He was so young. You know, who knows? I would love that to be the case. But like I said, yeah, if you can live that long and you are not a statue, you know, you're not like this mummified creature that, you know, they're having to spoon feed and wipe their butts and all that, and you can actually go out there and have a great life. I think that's the key, right?
I have three things to say that. Number one, if you want that and you pay for that and you have some royalty and you want someone to clean your butt, good for you.
Yeah. I mean,
two,
if you want it, right? Like, yeah, there's nothing wrong with
not having to have
with
it.
that, not having to have it. Yeah.
And number two, some of you need to die before 120. I'm just going to tell you right now, it's good for the population. It's good for Darwinism. Please don't live to 120, 150.
You gotta cull.
Some of you need to go.
Or you gotta cull. You gotta cull some of it out. I totally get that. Totally get that. Yeah.
But anyways, I think we've seen. And I think it's so interesting too. It's, do people take advantage of medicine, right? Do they take advantage of these knowledge? I feel like now when you die young, people are either missing things or not going to a physician and seeing that, oh my God, I have a 70% blockage and I just ran a marathon. That's a bad idea.
Right.
You know, they're not, they don't know. They think because they're running a marathon, they're healthy. And, you know, I think there's a lot of things that we can do there. But I do, coming full circle, I totally agree with you. It's going to be a very interesting few decades, I guess, and they believe they're going to be able to unlock it. And I do think we're going to have a lot of opportunities to treat diseases, have better cures for people, or better qualities of life. Mm-hmm. I think your specialty is going to change probably a lot in the next 10 to 15 years.
It's changing every year. I mean, honestly, to be honest with you, when I started interventional pain, I'll go even further back. When I was a medical student and there was this sort of glimmer of like, what is this thing? It seems pretty cool, to what I'm doing now, it is completely different. And so, and that's just let's say I started, I was a medical student in the early 2000 aughts, and, I did fellowship in, 2015. And what I'm practicing now compared to what I learned when I was a fellow, again, vastly different. And so I expect there to be change. I talk to my wife all the time, who used to be more into like AI search, and she's been telling me for a couple of years now, she's like, your industry is going to get so rocked. She's like, brace for it, because if you think that you're going to keep doing what you're doing now in 5 years, she's like, you're sadly mistaken. So she's always trying to encourage me, go to those talks, learn what's happening now, because there's a lot percolating that once it really starts to take off, everything is going to change.
You want to be on the front of the wave.
You want to be on that leading edge. You don't want to be, sort of like, you're like, no, I'm just going to do things the way it's always been done. And like if you're toast if you do that. Yeah.
So I'm going to bring this all together. And then the third thing I forgot, I'm going to go backwards here, is Logan thinks that when you hit 100, your time's done. He thinks you just clock out. I think there's something beautiful about that, by the way. I'm like, okay. He's like, you have. my birthday was this week. He's like, you have 50x years left. I was like, all right. Like,
I mean, if it's guaranteed to 100, I'll take it. I'll take it. Yeah. There was a Star Trek episode about that where the society would, like, after a certain age, like, they have to die. And so it's like, I remember from when I was a kid, I remember seeing this Star Trek episode. I was like, that's a really interesting.
Coming back to I just remember the third thing. Coming back to what we're talking about, and I'm going to bring this all. So I've known you for a while now, and you've always been data driven. You're always on top of things. And I think when you're looking for a physician, whether a specialist, primary care, you have to interview your physician.
Sure.
And you have to make sure that the person you're talking to is on top of things. I know you're going to do it right. You're going to ride that wave in the front with things that make sense, from a scientific and an approachable data-driven thing. And that's good. And there's some things probably out there now, especially in the longevity space that we were talking about earlier, that there's no harm, no foul. We feel like if you take these supplements, whatever, $100, $200 a month, if you can afford that, why not?
Sure.
It's not going to hurt you.
Sure.
Right? So it's going to be really interesting how fast it moves. And I play with this stuff too, just like your wife does. I'm constantly playing with AI. I barely use Google anymore. Gemini's good though. And it's going to be very fast and fascinating. People are going to have access to more information. Right. People are going to be utilizing it to get the results the way they want. They're going to upload an X-ray. They're going to upload an MRI. It's going to get really interesting. Right. And so I think being at the top of your specialty, of what you do, and being able to handle those questions it's going to almost be like the best people are going to do the best, I believe, because it's going to democratize data, and it's going to give you can go to a doctor and get 3 different opinions. Right. And there's nothing wrong with that. But I think the people that have the best outcomes and do the best job are going to just elevate themselves to the next stage.
Yeah, no, I could certainly see that. I could see that. Although on the flip side, it's interesting because I was thinking this is taking us in a different direction.
I have a feeling I know where you're going.
No, because I remember I was sitting in my car and I was remarking how many people were walking just with their phones, right? And I thought, man, it's interesting how society has gotten to the point where literally everyone they look at, they're doing this. And I started thinking, well, with AI, if everyone starts being so reliant on AI technology, I started thinking, are we going to become like Planet of the Apes, where we just don't know how to do things anymore because it's like AI is going to do it? AI is going to think for me. There's going to calculate for me. It's like, so I don't know how to do it anymore. AI is they write your speeches. People are like, I need to formulate a letter. I put it in. ChatGPT does it for me, right? Are we going to start losing those skills that we thought were what made us human, right? And again, this is a completely different segue, but I was thinking about this the other day and I go, is this, because you think about Planet of the Apes, humans, they lose speech, they can't, build tools anymore. They become completely stupid, right? And it was like, is this going to be like the next sort of like launch where AI takes over? It is the super intelligence and humans become this inferior sort of, like species that no longer knows how to do anything. Food for thought.
Wouldn't be surprised. How many of you know how to change a tire?
Right.
Huh?
No, yeah,
how many of you know how to drive stick shift?
None. It's like, I don't,
I told some kids, what's stick shift?
I will burn the clutch like nobody's business. I mean, it's like, I know.
Good luck texting and driving with one of those suckers.
Yeah.
No, it's interesting. And then the next question is, if you give so much information to someone, do they even seek help? And it's interesting because we're talking about a guest that my friend Rob wants to have on. We're not going to say your name until we have you on the podcast. And he's like kind of creating this divide between medicine and the new wave of wellness. And he has a huge platform. And I'm like, well, that's interesting. And he's put his flag in the sand pretty hard. And I'm like, he's like, oh, you can't. Number 3 leading cause of death is like misdiagnosis in a hospital. I'm like, dude, that's not even close to true. You can AI that,
right?
That, dude. Like, chill that out, man. But it's this distrust in the medical system and what we have now. And so, but I also think people are so used to utilizing insurance and understanding the pressures that are upon physicians to operate at a certain level, and they're not also willing to pay for it. But then they go and pay someone $20,000 for a red light bed. And it's like, okay, well, okay. So I think that the information is right now, there's this little war on medicine and healthcare, and people are seeking alternative methods of healing, doing better. And now you have this information that is flying through your hands. I just created a whole document, like 10 seconds. Now I've been working on that document for several days now, and I have to go back and fix it. But it's like the amount of information I can get is so much faster.
No, absolutely.
So much more accurate.
Yeah, but I think the problem is, and we have a lot of information, but the difficulty is in trying to distill what's good information and what's bad information. Mm-hmm. And I find that people latch on, like, and we all do this. Like, look, I did a PhD, and, when I'd have to go through all of these articles, I was looking for articles that would support what it is that I hypothesized to help me get to my conclusion, right? Similarly, I think, nowadays, because it's so easy to get information, you go, oh, I found an article that says, the measles vaccine is harmful, so therefore measles vaccine is bad. Look at this article. And I remember once I was in a procedure with a radiation tech, and he goes, oh, there was a white paper that says you don't need to wear lead anymore when you're working on the floor in front of a fluoroscope. And I go,
I remember that paper.
and I remember looking at him, I go, and what if they're wrong? Right. Do you want to take that risk? I was like, I certainly not with my health, right? No. Do I want to risk getting cancer? And I was like, absolutely, it's not worth it. So, I think there's always going to be data. And what used to happen is that if someone wrote some obscure paper somewhere, you'd have to go to the library, maybe pull out microfiche. Like, you really had to be determined to find that garbage piece of information. Now, garbage information is so readily at your fingertips that you can justify whatever it is that you say.
Yeah. And when you search, you're searching with, most of the time, some sort of confirmation bias. So
right.
You're getting exactly what you look for.
Right.
And as you know, especially through your PhD days, and we'll introduce you shortly, I can find what I want.
Totally.
It may be n equals 1, it might be n equals 10. But over time, n equals 10,000 versus the n equals 10, you're finding the articles, or depending, some people put it on all their, all these whatever med spas put on their thing, and that's what you find first, and now you're disinformed.
Right.
And that's actually super dangerous. And I got to say that he tries to tell people to do, but most people won't take the time. And from my background, I understand it. He does say you should learn how to read articles and published papers. Peter Attia talks about this all the time. And you should be somewhat dangerously educated on this.
Right.
It is very dangerous to know, where are your sources, where are they coming from? Are they coming from the NIH?
Right.
Or are they coming from, somebody's spa blog post?
Right.
So you got to be, you're right, you have just as much access, and probably more access to bad information than good information.
Absolutely.
Yeah. So be smart about how you look for information. So you kind of talked about it. I think you're completely crazy. MD, PhD, Dr. Lucien Alexandre.
Yeah.
Okay.
Crazy for a different reason, but yeah.
Awesome, dude. Yeah. I think, you just, and so tell me a little bit about your background, how you got, what you did, MD, PhD. We'll talk a little bit about the business you're in and what you're going through, and then we can just continue to have some fun conversations here.
Sure. I guess, background wise, I guess technically it's always funny because I think about this, especially in, today's, sort of crazy political environment. I guess I'm an immigrant. I never thought of it that way because, I wasn't born in the U.S. My family moved here when I was 2 from Haiti, and we moved to New York, and every sort of like my state of being and consciousness has always been in the U.S. because at 2 I don't remember anything, right?
If you did, that'd be even more interesting. But
that'd be a little scary. It's like, no, but so, I grew up early years in New York up to the, 6th grade. Then my parents, again, being from an island where they were done with the cold, and they decided to move to Florida. And so that's how I found Florida, or Florida found me.
Typical New Yorkers. No.
Right, exactly. And then so I was here through high school, and I left because I thought, okay, I can't stand Florida. It's too slow, too many old people. And so I went back to New York. I did my undergraduate training in neuroscience at NYU. And then while I was there, I started doing research. And so that's where my love of research initially started. Was working in a lab using an electron microscope, if anyone even knows what that means anymore.
So cool. What is that?
Yeah. And then I got to a point where I would have to say I was so scienced out for a little while that I wanted to do something a little different. So I moved to France and I taught English for a year while I was applying for med school. And then I applied for MD PhD programs because, again, I just really got into research when I was an undergrad. Came back and went to Albert Einstein, also in New York, where I did my MD and my PhD. I ended up doing my PhD in sort of the general field of stem cell neurobiology. I specifically studied what were the early correlates in mice brains for Alzheimer's disease. So looking at signals in stem cell populations that eventually give rise to adult neurons that may be susceptible to Alzheimer's disease later in life. And so that's what I studied. Spent way too much time there, way too long.
That's where it comes back to the crazy.
Yeah, this is crazy. I was like, way too long.
Good for you. I love it.
And then, at the time I was, especially when you're in the lab, again, so it was basically a neuroscience lab. So I did neuroscience undergrad, neuroscience PhD. I thought I got to do neuro something in medicine. So, and, when you're doing a PhD, the MD PhD programs, they don't give you the same amount of time to do your clerkships like if you're doing just a regular med school, right? And so where you get 2 years to kind of try things out, I think I had 13 months to figure out what the hell am I going to be when I'm done with this. And so I was thinking, I was like, I'm going to do neuro something. I don't want to do neuroideology because I don't want to stay in a dark room. I hated being in the microscopes after a while. So I thought, okay, I'm going to do either neurology or neurosurgery. A lot of people I knew who were in neurosurgeons who were just like, look, only do this if you can do nothing else in life, that make sure that everything else completely bores you and neurosurgery is the only thing you can be happy doing. And I realized I don't know if that's true, right? And so I ended up going into neurology, although at the time when I went in, I actually thought I was going to do endovascular neurology, which is still along those same lines of neurosurgery without having to do the whole grueling residency of a neurosurgeon. And then when I was in residency, I realized I hated stroke. I realized I was an angry person at 3 o'clock in the morning. It's like I'm usually a pretty chill, even keel guy, but if a nurse called me at 3 o'clock in the morning, like, hey, we have a stroke in the ER, I was like, why are you calling me? So I realized I'm probably not the best suited person to go into this line of work. And but I still knew that I wanted to really use my hands. And being a general neurologist, although I think it's an incredible field, but as a diagnostician, that's not where I saw myself. I thought I had good skills for that, but I also like the technical aspects.
Right.
So that's when I really started diving deep into interventional pain, and I fell in love with it. What was great about it was, you'd see a patient, even when I was a resident, I wasn't doing anything. I was just a guy standing in the room watching the others do it. Patients would come out, thank you so much for, and I was like, I didn't do anything. They're like, but thank you, my pain, I don't have any pain. And I thought, this is pretty great. The sort of immediate gratification of being able to have someone come in dire pain and have them leave, singing your praises because they were just happy that they weren't in pain, even if it was momentary. And I thought, this is a field I want to be in. And so I ended up leaving, after finishing residency. I ended up doing an interventional pain fellowship, and then that was in Boston. And then from Boston, I moved back to Florida, never thinking I was going to come back to this place, but I really just could not stay in the cold anymore. So so back in sunny Miami, and as I said, it's been 10 years, and and during the 10 years I've been practicing, it's just things have evolved, and like my skill set and the things that I've incorporated into my wheelhouse have changed fairly drastically. And it's been great, because now some of the things that I would have referred patients out to and say, look, you've got X condition, we've taken it as far as we can with injections. I'm going to now send you for surgery. And you'd see the look of fright, like, surgery, I don't want surgery. He's like, but there's nothing else we can do for you. It's like, but I don't want surgery. It's like, sorry, you got to go. Right. And so now there are so many tools in our armamentarium that allow us to treat patients non-surgically and give them the level of relief that they would have gotten had they done surgery without having to do something so invasive.
I would say it's a lot more non-invasive.
Yeah, absolutely. Absolutely.
So besides those procedures are super cool. That's how I met you in the medical device world, and we're plugging batteries and stuff in people.
Yeah.
And it was awesome. I remember I met you when you were coming back down here. You defrosted. That's it. You can't go back to.
I can't go back.
That's it.
I'm soft. I can't. Yeah, I can't handle it.
You speak French?
I do.
Okay.
Yeah.
You speak Creole as well?
I do.
Which is offbeat. Okay. Very cool. I grew up right outside of Little Haiti in Miami. I don't know if I ever told you that. I may have. Right outside. So a bunch of my neighbors were Haitian. So got some good food in my early days.
Well, hopefully you picked up some good words too. Yeah.
Not the ones I see saying in public. Let's just say those are the ones I know. I know how to curse really well.
No, it's good. You always got to start first with cursing, and then you move on from there.
Yeah. So, but yeah, of course, and they've stuck. But so I mean, there's a lot of things changing in your field, and we kind of started, our conversation in a different world. So, someone just told me today. I actually get your opinion on it because I'm sure it's viral. Is the mouth? There was just something that came out that went viral that the mouth has to do with. Did you see this?
Well, through my MA, because again, she keeps me young.
I was like, okay. And I have heard some dentists talk about it. Nothing wrong with that. And I'm sure there's different things in our mouth and different bacteria and stuff. But I saw this and it's gone viral online. It was talking about, I want to say, root canals creating dementia, and specifically Alzheimer's. Did you see anything about that?
So that specifically, no. I think we were going to talk about there's just like this sort of mouth insert thing that has now gone viral on TikTok that my medical assistant showed me. I was like,
what's it for?
Oh, I don't even remember. She showed me and she's like, oh my God, everyone's doing this now. Like, of course. It was like,
careful, don't do it. Everybody does.
I was like, of course.
But again, Darwinism.
No, it's interesting. I mean, I think that I'd have to see the data. I think, there is the brain is not very far from the mouth, right? So you could certainly consider if there's a, sort of bacterial infection that close, could it, potentially?
Does it do that cascade?
Yeah, maybe. I don't know.
I don't know. It's just interesting. Everybody's like, I'm like, oh, did you? As soon as I say, well, medical, they're like, oh, did you hear that?
Yeah.
Shoot.
Well, I remember when I was doing my PhD, there was another PhD student within my lab who was working. I was doing Alzheimer's, they were doing Parkinson's, and then there was this like big thing about like the gut and Parkinsonism, right? And so some of the early signs in Parkinsonism is sort of GI issues, and they were saying, oh, like, is there a corollary where this is where it starts? And I just don't know. It might just be similar cells. I don't know. I think the body is a very interesting, complicated piece of machinery that, if you tinker with this thing, does that, if you, sort of like you cause a ripple effect, and does that, I don't know, right? I'm open enough to go, I'm not so stodgy where I'm just like, this is all what the data says. But I go, look, if you can prove with good scientific evidence, I was like, there's possibilities.
It's just,
although it sounds like quackery, but still.
It's a butterfly effect in the body, actually. Yeah. There's so many things, and it's so complicated. We still don't understand it all. So you're telling me, you told us a little bit about your MD, PhD, and your background. So what excites you? What gets you super excited for what's coming, what you're able to do today, and that you completely love doing?
I love being in my field now because of the fact that we have so many changes and so many things that I think that have revolutionized how we deliver care to patients. And so, could I say it's this one particular aspect of it? No, there are lots of aspects. There are lots of things that I love doing, right? Although when I started doing my PhD, I did in stem cell neurobiology, I got sort of boxed off from a lot of my regen experience working in stem cells because I joined a hospital.
Regenerative.
Yeah. So yeah, regenerative medicine. And when I was working as a hospital employed physician and I wanted to do something as simple and crazy as offering platelet rich plasma injections, the hospital, they threw a fit. I had to go through committee meeting after committee meeting. And they said to me, Dr. Alexander, we're never going to do that. And I said, yeah, you give patients fresh frozen plasma, don't you? And they go, yeah, that's all I'm doing is giving them back their, no, that's just crazy. So for a while, I did not get to practice some of these things where I had a lot of basic science knowledge on. And then so once I left the hospital, I went into private practice. That opened up a whole new sort of field for me again. And so since you asked, like, what are the things that excite me? I think regenerative medicine has a huge potential. And I think, understanding, first of all, how we use it and how we harness it in the right circumstances, I think is a game changer, right? And I talk to patients all the time, and I say, yes, like, here's your option A, here's your option B, here's your option C, right? Option C may include surgery, right? And I tell them, it doesn't mean that surgery is off the table if we do any of these things, but, if it were me, if you're my family member, family member that I like, right? I would say, try this, and if it doesn't work, right, the worst thing that happens is that you wasted a little bit of time in terms of waiting to get to a surgery, but the surgery is always there for you, right? And so I think that has been instrumental in the way I practice now and what I offer patients, and I hope to continue offering it to them. And so we'll see with the FDA what sort of things loosen up or don't loosen up as we go forward. But I think there's a lot of recognition that a lot of these therapies are actually very beneficial.
So I'm not just interviewing you, I'll be a patient as of next week for this in particular. So I think it's really interesting because we're seeing people that are, come to Mexico, come to Colombia. So what are the advantages of leaving the country versus what the FDA is allowing you to do today?
Well, different cuisine, you get to travel. No,
I don't know if I want Mexican food before any sort of injection. No, I'm just kidding. The cuisine's good.
It's interesting because, and I've had some patients, some really smart patients who've come in and, they've done their homework and they go, look, I can go to Colombia and, for the small fee of $50,000, they're going to take, fetuses and they're going to grind them up and give me all their stem cells. Right. And it's like, isn't that great? And I go, no, that's, I don't know the advantage.
In Colombia, $500.
Right. It's like, I don't know that there's, and there's good reason for thinking that, well, if it comes from a fetus, it's got to be better because it's fresh, young, and
the most cellular growth.
Right. It's going to be the fountain of life for me. And I go, maybe that's true. But, in the US, because there was all of these regulations on using fetal stem cells in the US, unless, in very specific cases, it caused us to be a little bit more ingenious in the way that we approach this. And, there's more research that went into trying to figure out what sort of intrinsic stem cells are there and can we use those, and do those have the same sort of healing or regenerative powers as having using fetal tissue. And so, I think the answer really is that, maybe like babies are better, right? But do you need it, right? It's sort of like saying like, I've got a Bugatti, that has like, it could do like, 1,200, it's got 1,200 horsepower, and you go, well, but I've got this other car that does 600, has 600 horsepower. You go, if you're driving down Miami, is the 1,200 real horsepower better?
To 1,000 horsepower?
Yeah, it's like, is it better than the 600 horsepower? Probably not.
Does it get you where you need to go?
Does it get you where you need to go, right? And so 600 horsepower is still pretty damn impressive.
Especially in a truck.
Right. Exactly. The 1,200, you go, it's something to brag about, but I don't know that you need it. So similarly, I think using mesenchymal stem cells which is what we find in our bodies as adults, they have the potential to still repair and heal a lot of the tissue injuries that we're hoping to heal. And I don't know that you need to fly to a Colombia or a Mexico, what have you, to get fetal stem cells. And then I always go, look, I think about this, from a very basic science point of view. I go, if I'm taking a cell that is not my own, and I inject that cell that is not my own into my body's going to see that as foreign, right?
Right.
So the thing it's going to do, it's going to try to take out as many of those things as possible. You're going to have some residual that makes it through, but how much is left? And then there's also the thought and the concept of, these are stem cells that are pluripotent, right? They can become almost anything. They can also become a cancer cell.
This is why I haven't done IV. We'll get to that.
Right. And so do I want something that is one, sort of foreign to my body, two, that has the potential to become a cancer cell in my body? I don't know that I'd want that. And if you go to someone, you say, look, but you have a repository of stem cells that will do the job. Again, is 600 horsepower good enough, or do you need the 1200 horsepower?
Right. So that's interesting. So, I mean, and I've heard this case too, right? It's like, okay, we're still relatively young. So, from a PRP standpoint, like, are my platelets good? Or do you get the platelets from an 18-year-old or a 16-year-old or a 12-year-old to help repair? Because theoretically they're younger and they have more horsepowers, we can call it. So, we're still waiting on data. I mean, like, you kind of said what you thought about that. I don't know if it's worth flying somewhere else. The second thing is, obviously here, there's some restrictions for a reason.
Right.
You guys are very well educated. It's a super high standard to become a physician here and to do any sort of injections. Now, I don't know if there's some loopholes there, because I've seen some quackery.
Yep.
A little weird. We've talked about it. I don't know if we should go that hard, and I'm sure Rob wants me to. But where people are paying $100,000 for head to toe stem cells, right, and doing the IV stem cell. But we went and toured one here that utilizes stem cells that are allowed to be bank. They have gone through the highest of standards. It's at a university, and they're able to utilize them somehow. And I don't remember all the information. You can ask Dr. Miranda on that one. But it was interesting because they've been cleared. But the one thing I asked, and we were with their PhD, I was like, so data safety on the IV stem cells. And they're like, exactly what you just said. We haven't, they're going through the clinical studies now and looking at it. Right. And it's like, is it worth the bang to maybe get a few years early, or to have that understanding that, okay, my percentage of this happening is 0.05, and I can make the most educated decision for myself. Right. Now, we have patients that have done it anyways against that kind of conversation, even with Dr. Martin. And I understand that side too. Like, why would I try to give myself the best? But I think there's a good thing to slow down a little bit. And I think there's such a humongous swing upwards. But I know where you were, so you weren't allowed to do anything from a regenerative standpoint, but things have changed tremendously since your hands were tied, literally.
Oh, absolutely.
To when you came out, and even till now, and we were talking, I think it was off camera, that like it is changing so fast. And you told me the last time you and I were having a personal conversation that physicians are grabbing their data and putting it into like a data center, so there is data on all these procedures. Right. So, I mean, where do you see it kind of going, or are you excited for the data coming out and having robust data?
No, I think that, so being able to collate your own data, because patients ask, and a lot of times I tell them when they say, look, what's the likelihood if I do a stem cell injection into my disc in my back that I'm going, and I go, I don't know that there's enough data to say it's going to be 70%, 80%, 10%. There's just not enough information out there. But you're finding that a lot of physicians are starting to collate their data, upload them into these data banks, and say, okay, I did an elbow injection of PRP using this concentrate of PRP. These were the results. And then so over time, you start banking all this information, and you go, okay, now I'm seeing trends, right? Now I can tell you, okay, based on my trends, here's what we expect. Now, again, every person is different, and it's you can't always say that what happens with patient X is going to be the same as patient Y.
There's no miracle pill, no miracle injection.
Right.
No medication works for 100% of people.
Right.
We're very complex.
Right.
You and we're walking, we have the same organs, we react differently to medications and all sorts of things.
And even the things that do have more robust data, they're sometimes conflicting. Like, is platelet, is leukocyte rich or leukocyte poor, PRP better for a knee? And then you'll read articles and you go, one says yes and the other one says absolutely not. And so, I still think the data is still very nascent. I think it's getting better. I think there's enough there to still say, look, it's worth it. Why do I say it's worth it? Because again, if I'm doing PRP, we're taking blood from you, we're spinning it down, we're re-injecting it, and we're just giving you back what was already in your body just in a concentrated form in one area to basically tell your body, here's an area of injury, go work here, right? And if it doesn't work, I think, again, fine, right? Same thing with stem cells. As long as you're using your own stem cells and you're not, having it manipulated in multiple ways, and you're still saying, okay, I want your body to basically find this as the problem, try to see if you can heal that. Again, if it doesn't work, fine. But I do think that the more these things are being done, the more data will be had. And then we'll also be able to hopefully get payers, commercial payers, to say, okay, we can't hold back the request for doing these because the data is just so compelling, and we're going to have to offer these to our patients, right? Yeah. And it's sort of it's counterintuitive, because sometimes you'll find that the simple things, insurance companies will say no to, versus, sure, I'll pay for like a 10-level fusion. And
you stole this right out of my mind.
Right. It's like, wouldn't you want to try this?
$100,000 surgery.
Right.
$2,000 pay me to do the injection.
Right. It's
and
like,
then do the $100,000.
Right. Wouldn't you want it? And so, but that's just the way our system is currently built. And so it's not always data driven, unfortunately. Even, for something, for instance, the VA, because there's enough data to support using PRP for tennis elbow, right? Lateral epicondylitis. Go try to tell Blue Cross that and say, hey, the VA allows it because look at the amount of data on this one particular thing. Now, can I extrapolate that for the shoulder or for the whatever? Probably not, but still, at least for this, it's experimental. At what level, at what point does having experimented and showing data and showing robust data no longer become experimental? That part I can't answer, because they get to make those decisions.
I'm so glad you're practicing this in Miami. I really am. I've had at least 3 injections. So my AC joints, I'd play water polo, and I would have to take ibuprofen. It was just like from overuse. So boom, boom. It's been 7 years. Gone. Just done, right? And then I did get the elbow as well. Same thing, water polo, this elbow, and it was driving me crazy. It was like just driving me crazy. Did the injection, the gnawing pain went away. And then I had some tight muscles. That was one of the worst massages I ever had. That was a different pain, but the pain that was driving me crazy was gone. Right. By the next day.
Yeah.
And then I had a massage that was terrible, and then I could straighten it, and it felt great again. And a couple of weeks later, I was good, and then that's it. And so, and then we were talking about my shoulder, and we're going to get to that on a personal level. I tore my shoulder. So I'm a big proponent. I've seen it work for me, and I was just dealing with this constant pain in these joints, and then in my elbow from the tennis elbow from overuse of it. And I think there's just such a great opportunity. It's unfortunate that it's being held back, but I think, again, coming back to what we're talking about, as we have more data and people have more access to this data, whether payers pay or not, there's going to be a great opportunity for people that are performing this at a high level.
Right.
And there's a humongous swing to wellness and being better and all these things. And those kind of people that are spending trillions and trillions of dollars in wellness, if they have a problem, they want to stay active.
Right.
Like people like me and a lot of people, they're willing to pay that X amount of dollars to do that. And it's funny because my copay for surgery is the same, more or less, as it's going to be to do a pretty advanced stem cell injection, right? So I surgery is surgery, and the recovery is completely different. Right?
Absolutely.
There's not many, it's a completely different invasive or non-invasive procedure. I'm in a sling.
Well, and the risk, I guess, I try, when I have patients come in, and I try to tell them, do not minimize the risk of going under, right? And so when I have a patient come to me and say, I want to be under for an epidural steroid injection, I go, are you sure? It's like, I don't think it's worth it to be. I tell them, I do not think it's worth it. And they go, yeah, but I don't want to see needles. I'm squeamish. And I go, you may not come out of anesthesia, right? And so the risk to doing surgery is not negligible. Thank God, like in the US, we have, great facilities, and, we're all trained to spot an issue, and the teams that work on the anesthesia teams are superb. But stuff happens, right? And people still, whether you're famous or not famous, don't walk out sometimes. Like, remember Joan Rivers? She went for, and she ended up dying under anesthesia. So it doesn't matter how much money you have. And so I go, if you could avoid having to go through something so invasive and having to go under, I would try that first before having, getting things sliced, and, then there's a risk of infection, and then, having to go back and redo the surgery because it didn't take the first. So I go, slow it down when it comes to doing surgical procedures, and try the other things. Again, as long as it's within reason. If someone says, hey, Dustin, for your shoulder, I've got this great remedy, you inject olive oil into there, and it's going to be, all right, then you have to be, you have to say,
olive oil.
You have to say, exactly. I like it on my salad. I don't know if I want it on my shoulder. You have to be discerning, right? It shouldn't be just try anything and everything, right? And see what sticks. No, but, as long as it's within reason, there's good data for it. It's safe. I think, I would by far recommend those things before going through surgery. Unless, there's always a caveat, right? Your shoulder is like,
completely detached.
Yeah, it's like, no, you need to go surgery. Like, there's no injection.
Your spinal column separated.
There's no injection helping for you for that. Please go to a surgeon stat. Go right now.
So you went from working, and if there's more you want to talk about in this world, please don't stop me. I will ask you towards, in a little bit, if there's anything else you'd like to talk about as well. But you go from working for a hospital, everything's integrated, and then you work for yourself now. You're a solo practitioner. You made the jump. What are some of the hard things that you went through to get this going? You obviously talked a little bit about payers and things like that. Throw you a little bone there. That's easy to talk about. But what are some of the things that you had to learn, and what some of the things that you helped yourself, or you're still working on to scale your name, your brand, and the way you're able to help so many people? Yeah,
it's I'll tell you, I wasn't so smart early on, right? Because you mentioned my name, my brand, right? Because when I worked for the hospital owned me, right? It's and I only realized that once I left the hospital. And my Google reviews, I had no access to it, because the hospital owned my Google reviews. They owned my name, right?
We're going through this with a hire right now.
And so trying to decouple myself from the hospital, I realized took some time. And then when I first left the hospital, I joined a private practice, which I didn't stay at. Right? I was there for a couple of years, and there too, I was, I sort of attached myself to that practice. And then I realized, very quickly, wait, I need to own me, right? I represent myself. I need to be the one in charge of my Google reviews, my website, things that I want to have shared and shown with patients. And so, and also if I wanted to move to a different place, that patients could find me, right? And so those are things that I think are incredibly valuable lessons that I learned along the way. In terms of, being in a private practice, it's interesting. I spent a lot of time initially trying to go sort of more doctor to doctor, but those happen in ebbs and waves. Like, sometimes, someone remembers Dr. Alexandre. It's like, oh yeah, Dr. Alexandre. Send you a bunch of patients, and then squirrel, and then like for months go by and you never see a patient from them, and then somehow your name comes up and they're like, oh, they start sending you patients. And so those referral bases, they're very, very unpredictable. And I realize it's better to go straight to patients and be more patient facing and provide information for them online to find you. And I realize that they will find you. They see, they see your website, they click on it and they send in, sort of a request, can I see you? I have this condition. Do you treat this? And then we get them in. And so I found that to be much more beneficial in terms of building the practice for me rather than the doctor. I mean, we still do that. And we try to foster those relationships with other providers. But I realize that the word of mouth, going directly to patients and patients bringing in literally their entire family, they come see you, they go, okay, I love you. And then I'm sending you my mother, my tia, my cousin, my dog walker. Then, that I think has been wonderful. Yeah.
Yeah. We talked about this a few times on the podcast. If you treat people well, have good outcomes, it will spread.
Yep.
Yeah. And it's the best way. And people just love it. I haven't been able to do anything online, and we're trying to utilize that now, but honestly 98% easily, if not 99% of our referrals are patient by patient.
Right.
It's patient to patient. Talk about the practice, Dr. Miranda, Pure 6, 7, 8 times, and finally that person comes. And I see sometimes on the online form, they look it up again, make sure we are who we say we are.
Right.
Like, oh my God, this person told me about you. And it's like, and then that person comes in like, yeah, I told her like 3 years ago. And it's okay, it takes time, but it starts to build pretty quickly as you start to go and you build those relationships and they spread like wildfire. If you're able to do your job, which can be complicated depending on where you are, and do it well, people will find you.
Absolutely. Absolutely. No, and I think that's been a really valuable lesson that I've learned, and and right now, we're doubling down on it. I think that is the best way to reach patients and to continue growing.
Yeah, and the best investment you can make is in yourself, in your practice. And so, is there anything I haven't covered that you want to talk about for the gram, or not for the gram?
No, I mean, I think this is a great conversation. We've gone from from AI causing human civilization to completely crash and become like the Planet of the Apes.
I'm going to read a book. I'm going to read a book with you about this, by the way. We're going to read at the same time so we can talk about
all the way to practice building. I think that is spanning the gamut.
I think so too. We're going to get you some more physicians that need to send you patients. Obviously, we do our best. But I think it's important for physicians to network with people that take care of their patients. You're like, just like I augment my intelligence with AI, you're augmenting the way you treat your patients by who you send your patients to. And so I think it's important to have a good network of that. And that's why we love working with you and have since you've been here, except when you moved a little far. But now that you're back, baby, I know. Now that you're back for a little while now. So
that was hospital imposed exile in order to comply with their non-compete. So
well, it's funny because we've talked about this. There's a couple of hospitals that we haven't been able to talk to anybody there because their non-competes are pretty far. And I'm not going to say we don't have one. We have to protect our business too. But at the same time, a couple of them are pretty wild. Like it's like
can't practice in the state of Florida.
Hey, you gotta go to another planet. It's like, hey, dude,
what about open waters? No, I can't do that either. It's like, Jesus.
1 mile offshore is freaking international waters. So it's kind of interesting. But as always, it's always a pleasure seeing you. I'm glad we got to do this. I am going to next week. I'm going to hold you accountable when we do our appointment. You're going to record it, so we have some more material for you. And then I'm super excited to see how your practice grows and it evolves. And you're going to keep me young forever by putting my own stem cells back in me, and we'll take it from there.
I love it. I'm like I said, very, very excited. I for some reason, when 2025 started, I'm like, this is the year, man. I'm like, this is this is a year to just make everything happen. So
Yeah, and you just start planting those, and it's everything's compounding interest, right? You made a decision to go on your own. You're doing right by the patients. It keeps growing, and the next thing you know, you're like, you went from like, I was complaining about that 2 years ago, or I was thinking about that 2 years ago, and like now I'm like, oh my God, it all happened,
Right.
and it happens slower but faster than we think too.
Absolutely.
It seems slow because we're day by day, but then you look back a couple years like, oh my God, this is kind of nuts, and it's kind of great. And then your mindset changes a little bit of what does this look like? What do I want it to be now? And you start even dialing in more and more and more because you have that freedom and you have different kind of decisions to make and you have different things to treat people with and different things that you can bring on board to help people. So always a pleasure.
No, same here, man. Love it.
Dude, my man.